Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Thank you for joining me again today, Jack.
My pleasure, John.
Today you wanted to talk about diagnosis
Yes.
and what it means in the context of, not only the pathophysiology of that, but what does it mean for what presents, and then what does it mean for the rehabilitation process, and how does that vary? Sometimes we see diagnoses that create some sort of limitation to how people maybe address the problem, but we kind of have seen a few sort of aberrations in what we think may actually be the most appropriate approach, even though the so-called evidence or protocol suggests that you should take another path.
Yeah, and associated with this is understanding what information pathoanatomical structures give to you about prognosis and management in general.
Yeah, I think the perfect example of this is, say, like spinal pain, where, I remember the paper thing came out in about 2015 or so. That suggested if you actually tracked across the decades degenerative changes to the spine, you find that in asymptomatic patients there is a large percentage of people that have things like disc degeneration, joint degeneration, the presence of arthritic changes starting to occur,
or other disc pathology.
Other disc pathologies developing. However, all of these patients that were MRI imaged were actually asymptomatic. And it showed that basically this degradation of the spine, or at least the structures from a pathophysiology point of view, was normal. And I remember you sharing a paper that suggested the big differentiator seemed to be whether that pathology was in the presence of an inflammatory, or the inflammatory status of that individual. And if there was inflammation present, typically that pathology presented with pain, and then if it didn't, then they wouldn't actually present with symptoms necessarily based on the pathology that you saw.
Yeah, and that highlights the issue associated with just purely the biomechanical model of looking at musculoskeletal conditions, because although it has relevance, and depending on the context, it's going to have a lot more relevance than in other situations, it's not the only thing. And part of that is related to understanding that, particularly something like back pain, there's a lot of complexity to it, and we really probably should look more at back pain as a type of chronic condition that really is multifactorial.
Well, obviously non-mechanical kind of back pain, like if someone gets hit in the back with by an opponent or something and then they present with pain, that's probably pretty mechanical.
Yeah, and this is where you need to think about context in terms of population group, because if we think about the general population, more often than not, we're going to be dealing with problems associated with not just potentially the state of their musculoskeletal system, but other systems within their body, specifically like their immune system and their hormonal system.
Yeah, well, I think that gives us a bit of context to start exploring. When someone arrives at, say, some sort of diagnosis such as non-specific low back pain, which is typically a lot of people will present without maybe the mechanical symptoms, sciatica, clear nerve compression or something like that. Typically, it's often very difficult for people to ascertain, what structure is causing the pain. And if you do image these people, sometimes it comes back with almost, very normal findings. It suggests that there isn't actually anything going on from a, pathology point of view.
You see that a lot too, not just with the spine. I know certainly with the hip, there's a lot of research showing that age groups associated with developing OA who present with symptoms of OA, who actually on imaging don't have any indications of degenerative changes at the joint. And conversely, again, seeing people that have a lot of osteoarthritic or indications of osteoarthritis on MRI yet being asymptomatic. So you see quite often this decoupling between what the image finds and what the person actually presents with.
What do we do about this? Because it seems like it's a deep hole to go down. As soon as you start looking at this, you start to consider, if this is what's presenting, but I'm not seeing these changes, say, on imaging, how do you actually address the problem? What are the things that potentially you need to start looking at? What are the areas that you need to start exploring? Because it can be very frustrating as a clinician. It can be very frustrating for the patient because the patient wants a clear diagnosis often.
Yeah, absolutely.
They want to know, okay, well, what's damaged and what's causing the pain.
And look, you and I have talked about this recently of some of the dangers you also run into with not giving a clear diagnosis. And it's a bit of a double-edged sword in that sense because patients typically like a diagnosis because they like to be able to identify with a particular pathology or condition, but depending on their perceptions of that condition, they may have a lot of negative connotations associated with that.
Yeah, if you say, okay, well, I think it's discogenic in nature or whatever, then all of a sudden they start to have these strong ties because the context with back pain is that at a cultural and societal level, we see disc injuries as being severe, as being typically long-term and potentially something that will have, future effects.
Yeah. But yeah, going back to your question of what do we do with this? Well, context is important here because like you mentioned before, if someone came in, say, following direct trauma to their spine and you suspect, say, a fracture, then yes, okay, that's going to require specific management and that will often, more than not, require, say, investigations to confirm or refute that diagnosis and then may require medical or surgical intervention.
Do you think that, do you think that often enough clinicians will diverge their thinking at that junction? One of the first questions I think that's really important to ask, obviously you want to know where the symptoms are presenting. The second one seems to be, okay, did this occur in one known incident, right? Or is it something that has come on over time? Because that seems to straight away, that will diverge your thinking for what is potentially driving this issue.
Yeah, and look, I think even if it does develop over time, again, you're going to be determining what are their symptoms like. Let's say, for instance, they're presenting with neural symptoms or potentially more sinister pathology when you're thinking of something like quarter equina syndrome and things like that. But the reality is most people who present with an insidious onset, it's very vague and non-specific in terms of their pain presentation. Well, I think the one thing that's clear, and you see a lot of people advocating for this within our profession, is to not over investigate in the sense of doing radiological findings for particularly that population group who, based on your clinical assessment, don't fit into either having a very specific type of pathology or probably even more importantly a pathology that does require radiological assessment to determine whether, say, medical or surgical management is needed, because it's becoming more and more evident that for the majority of people, the correlation between their radiological findings and their clinical presentation may be very poor. So I think that's something that's always important to remember is why do you actually send someone for a scan? Do you send someone for a scan to investigate what potential structures are involved? Do you send someone for a scan to confirm a clinical diagnosis? And I certainly work within the latter of going, well, I suspect this is what's going on. Do I need to get further investigation to do this? And again, sometimes that's really clear. A really basic example might be someone with an acute knee injury who you suspect has an ACL rupture and maybe a good candidate for surgery. Well, it's very likely that they're going to get an MRI to determine that diagnosis and determine the severity of it before getting, say, an orthopedic opinion.
I think this opens up an area that I think is becoming more popularized because of sport and people's viewing of sport. It's things like, say, imaging, muscle strain type injuries.
Yes.
We see this a lot now, even at the level we're working at. Well, we obviously work across various levels. So with the elite population, yes, it probably makes sense to image someone straight away because you want to get a really clear understanding. However, we're seeing it more and more even at lower levels. School-age children will request to get an MRI following, say, a hamstring strain injury. And there's clearly the cases that may be indicated. Say someone who you think has, like, say, an avulsion type injury or a proximal tendon injury that potentially may be a candidate for surgery, as you mentioned before. But there's more and more desire for these scanning to occur. And I know we had this conversation very early on in this podcast series with Brady Green, and even some of his work was quite interesting. He suggested that one of the medical staff at Brisbane Lions, and I think he's moved on now, but always suggested that he wouldn't scan things unless there was a real clear need for it, because you would end up finding things that potentially would change your management, but didn't necessarily need to. And I think now that MRI technology is getting so good, we're finding a lot of, say, small tendon involvements within these sort of strain injuries, and we're changing the management based off that.
Yeah, I think there's two elements to highlight here, because again, even from a research perspective, there is literature looking at when you have, say, intramuscular tendon involvement, how does that influence the prognosis of return to play? Now again, this is where it's really important to think about what research provides. It provides probabilities. So on average, you will see that when you have intramuscular or particularly free tendon involvement, you're going to have a longer time before you return to play. But if you look at the variability, it's huge.
Yeah.
It's massive. And the crossover between having tendon versus no tendon involvement is massive. So yes, on average, we know that it may indicate a longer return to time to play. And again, we can consider how much tendon involvement is there. Is there displacement? If so, how much? That may indicate surgery as well. But there's clearly other factors involved associated with someone's return to play status. And to your point that you mentioned before about clinicians or clubs using MRI, I sometimes get concerned that we are relying too much on radiological investigations to determine the prognosis and forgetting about some of the clinical factors that give us information about that person's status
and their
return
function.
To play.
I think now that we can more, with more acuity actually assess someone's function. We've spoken about obviously, our association with strength by numbers and their axis system. Our ability to measure things like their force output with a higher level of accuracy, their rate of force development,
Absolutely.
What their force curves look like, jumping capabilities, all of these things, I think that starts to give you an indication of when they're ready to return, irrespective of what structure was injured.
Yes.
And that to me seems to be almost more important. If they're not showing that they've reached certain capabilities, they're not ready to return. It doesn't matter whether it was an injury that didn't involve anything other than maybe some, fascial tissue versus something that clearly had involvement of, say, free tendon, right? If the one with the free tendon is showing that there's clearly some improvement in those factors and they're being able to create that, and they're obviously covering off on those clinical tests and some of the functional tests, then maybe they're getting closer than the person who's not doing that.
Yeah, look, absolutely. And I think a good example that really highlights that, for the average type of soft tissue strain is if you are to scan that person when clinically they are able to return to play and are back performing, there may still be pathology.
Yeah, you still see like the healing and some of the tissue actually
Absolutely.
Still remodeling. And that's interesting because I remember reading a study that basically suggested the greatest indicator of when someone was ready to return was pain on palpation.
Well, and what the other big factors are is the patient or client's perception of when they return to play, and even the clinicians too. And I mean, yes, of course, some clinicians are going to be much better at being able to determine the prognosis and return to play than others based on experience and knowledge. But there's also some psycho-emotional factors that you develop in terms of setting up people's expectations as well. And I think that's actually quite a useful tool that I always do is think about asking where the patient's perception is versus mine, and to see is there agreement or disagreement there, because that can also be advantageous in the sense that you are in agreement and therefore you're working on the same page, or whether there is that disagreement which also might require a change of expectations to make sure that the person's in a safe position to go back to doing what they want to do.
And it's an interesting one too, because I've been thinking about this concept quite a bit of how in certain sports there's a lot more conservatism than in other sports, for instance.
Yeah.
So like, I'm very heavily interested in watching, say fighting, boxing, MMA, UFC kind of stuff. And I enjoy sport in general, so I'll watch lots of documentaries and things. And there's two examples I'll take from that I think kind of it seems to be in contrast to what I see in, say, the sports that I'm involved in. And the first example for those people who do watch things like UFC, I found it super interesting that the Australian lightweight champion, is it featherweight or lightweight? I can't remember. Anyway, Volkanovski, right, who's UFC champion, and he's the featherweight champion. He, in the second round, I think it was, of a 5-round fight, punched his opponent against Max Holloway, and he's like, I felt my hand break, right? He kept fighting for another 3 rounds and dominated the fight, won it easily. It was the third fight between the two. Absolutely, put it to bed that he was better than Max Holloway, who's considered one of the best ever at that weight category.
With a broken hand.
And after the fight, you see him, he's walking down the tunnel, and he's saying, I broke my hand. He's like, my hand's broken. And then he put up an X-ray, and he's got, I'm pretty sure it was a fracture in his metacarpal.
Yeah, right.
So the fighters know, they know that they're injured. But he kept going. Now, I understand, it's only a short period, but in a lot of other sports, if someone fractures something, they're done.
Yeah. And
another example I would give is, even only this week, I was watching, I love sport and sport documentaries, so I was watching a 30 for 30, and it was the history of in the NBA, the rivalry between the Celtics and the Lakers. And during they had a big sort of rivalry in the 60s, and then it sort of booted up again in the 80s, and it was sort of the Larry Bird versus Magic Johnson sort of show.
Sure.
And one of the other big players for the Celtics was Kevin McHale, right? I think he was their big power forward. And I think it was the 87 series. He played with a broken foot. And he would just tape it up and he would play.
Yeah.
Right? And I'm sure he was probably getting injected, with something like xylocaine or lignocaine or something like that. But if you're going to go down the conservative route, you wouldn't let someone play on that. But as a player, they want to play. And 2, what does that diagnosis actually mean if that individual can actually carry out the task at a reasonable level? And I think one of the things that I'm noticing in some of the sports that I'm involved in, I'm not advocating in any way being silly or playing or training with injuries by any means, but I find it very interesting the context in which some sports and some environments, say if it's like the final series in the NBA or is a championship fight, are willing to actually go around whatever the findings might be, or they're willing to push through them, right? And that's an accepted and reasonable management in that sport at that time. Whereas we don't necessarily see that in a lot of other areas. And I probably don't even realize, I don't even really know what the point I'm making is, but I just think it's interesting how that changes so much, even though the diagnosis would, in one sport, would be ruling someone out, and in the other, they're like, I'll just keep going until this season's over or this thing is over.
Yeah, but I think what you're highlighting here, though, is challenging expectations again around pathology and injury. And look, another good example, and I know you actually have had some direct influence on some of this research, is looking at application of load following a soft tissue strain. So if you look at all of Monica Bayer and Jack Hickey's work of, can we start to actually apply some quite heavy and potentially eccentric loading with soft tissue injuries in that very acute phase? Because again, if you think about it logically, if you've got this disruption of fibers, do you want to apply load that might create more distraction? Doesn't that seem counterintuitive? But then if you actually look at the literature showing, let's apply early load, what happens? There isn't a detrimental effect.
No.
And in fact,
there's
not
probably benefit, yeah.
Well, not surprisingly, you restore, say, peak force capacity sooner because, one, you mitigate the detraining effect, and also, 2, you're probably stimulating a lot of positive healing by getting the surrounding soft tissue to contract and to secrete certain, say, myokines that influences that immune response that regulates how the tissue actually heals over time. But, the reality is a lot of people would assume that day 0, day 1, there's no way that you're going to apply any type of mechanical load to it.
No, well, I remember the discussion when I had it with Jack Hickey. I think he had sort of been thinking about this concept, and I don't even know how they got onto me, but this, we caught up. And he said, okay, if someone gets injured, how early would you start loading them? And I said, if someone strains their hamstring at the track, often we'll drive from the track to the clinic and start loading. And he goes, what do you mean? I was like, it's about 15 minutes later.
Yeah.
And I just remember him saying, like, what outcome is you're having bad outcomes? And I said, no, we're getting people back to running fast pretty quickly.
Yeah.
And I know, like, there's lots of examples of this. And I think another example that I saw that wasn't anything to do with me, but I know he's spoken about it a bit, is Chris Caviglio with one of the decathletes that went to the Olympics. I don't know, it was only about a 2-week period. He strained his hamstring, and then using consistent loading, and particularly the blood flow restriction training, which Chris did his PhD in, was able to get this athlete to the Olympics and performed quite well. Unfortunately, I think he no-hided in the pole vault or something, so his competition was basically over, but finished the whole decathlon after straining his hamstring. I think it was at least a grade 2, 2 weeks before.
Yeah.
And it just shows you that if you can apply appropriate stimulus to the tissue, it will respond. And it does, and the imaging, if you look at that, you go, oh no, that's probably going to be 6 weeks.
Yes.
But you've got 2, so what do you do?
Look, absolutely. I mean, again, part of that issue is that expectations element, but I think the other thing too is what this really highlights to me is your sensory motor system is very good at finding strategies to maximize output when needed. And like the reality is for these athletes, these examples that you give, there's a lot on the line, and they're competitors. Like they want to compete. They haven't trained for 4 years to get to an Olympics and then to go, oh, I can't compete. They're gonna be willing to push the boundaries to actually at least give it a go. And so it highlights to me that we have to be careful of thinking of that like kind of pure sort of classical mechanical model of there's a loss of structural integrity here and therefore it's impossible to actually perform at a high level. Like clearly your sensory motor system can do a lot to go like, okay, well, what kind of strategies, even like at a neuromuscular level, can I do to try and mitigate forces through here and alter force distribution within that compartment or around that compartment? And therefore you actually lead to a pretty good output. And again, that makes sense from an evolutionary standpoint because if you got injured...
Yeah, you're not going to stop. You're going to get eaten by a mountain lion. You can't stop.
Exactly. So... Again, there's always parameters here. It's not to say like just go for broke and just
push through.
Exactly, but clearly
they always talk about this. Like a lot of top coaches and even it's mostly coaches that talk about like the best athletes are the best compensators.
Yes,
like they find solutions around problems. And as you said, it's not that we're trying to advocate necessarily forcing someone to have to find solutions around injuries. But I think it opens up the concept of, okay, what does a diagnosis actually mean?
And look, you and I have talked about this too, and this is, I think, very relevant for elite sport, is what is the role of sports medicine and high performance teams working with an athlete or a team itself? And really, if you're an elite athlete, you're there to perform. And, particularly if you're a professional athlete, you're paid to do that. So really, you are trying to push them and be on the edge of maximizing their performance and output because ultimately their success is based on how many games they win, and whether they win the series or whatever it may be, whether they get a podium finish. I think
that's like, I remember talking we've got some colleagues that obviously worked through, Melbourne City and all that kind of stuff. And one of he's a great guy, and shout out to him, Ralph Napoli. He runs the sports science department there, I believe, and he's sort of now I think he might even be in an assistant coaching role. But absolutely fantastic guy, really knowledgeable person in the world of world football. And he, we had some of these discussions around some of this stuff and how these things kind of fit together. And one of the big things that he always spoke about is, like, I'm heavily evaluated on availability, right? He's like, that's the key metric that the high performance manager will come down on me with, that the coach will come down on me with. At the end of the year, my contract basically rides on, can I keep people available?
Yeah.
And I don't know that that's being used enough by, the management of these organizations of like, how available is someone and how quickly can you make them available?
And look, I look at it too as, it's relevant for even us working in our environment of, you can always be that conservative person like, nah, you got to wait another week, you got to wait another week.
And it's easy to be safe, but that's not your role maybe in that setting.
No, and like, what are you sacrificing in terms of that individual's ability to perform, and then therefore like the team or club's ability to perform? And not to mention like the expectations that you set up for that individual based on, potentially getting back in 2 or 3 weeks versus 5 or 6 weeks. There are expectations you set up about how that person perceives their injury and like what they can actually do. So I think it's something we need to be careful of, because it's always easy to go like, no, you got to wait, or no, I don't want you to do that training stimulus, because that's the easy option, isn't it? Like, I'm just going to take risk out of the equation, but then you also take out the opportunity for performance to occur as well.
So, like, going back to the diagnostic side of it, what do you think are things that people or even at least, what's your sort of thinking process about, okay, when do I need imaging? And if I do receive a specific diagnosis, this actually, I'll be very open with this and honest. I'm struggling with this concept at the moment, right? Where we always speak about the idea that we use principles to guide what we do. And we've often been quite critical of people who will use protocols based on a specific diagnosis.
Yeah.
So I've been struggling recently when I get particularly given a specific diagnosis, and the imaging confirms that, and the general protocol is you do this, and it's seen as being maybe too aggressive to do something that follows first principles. Where do you think for clinicians that we go with this? Because you don't want to be some crazy maverick who's just doing, overly aggressive things. But at the same time, if we don't necessarily have the information to suggest otherwise, is using first principles the approach that we can take?
Well, I actually think a good place to start with is, again, going back to looking at the fact that we see a lot of variability in outcomes associated with a pathology. So, you could have 2 individuals with the exact same type of injury, yet their outcomes are very different. And, like we've talked a little bit about this recently with, say, like certain types of stress fractures where some people seem to not heal while others do. Now, the question we need to ask ourselves is, do we think that's completely random and that there's things out of our control?
That's one of the things that's frustrating me. Like we've been discussing a patient that has a stress fracture in their pars interarticularis, or a lumbar stress fracture. And the research is not helpful. In fact, it's confusing. All right. And it's not to suggest that the people doing the research are not very clear on what they're trying to find. But it basically says exactly what you mentioned. Some people heal when they do nothing. Some people heal when they don't, when they do some loading, not necessarily high level of loading, but some loading.
Yes. Some
people don't heal when they, do loading, and some people, it heals when they do loading. So there's 4 different outcomes from 4 different approaches, and it doesn't seem to necessarily, there's 2 outcomes from the 4 different approaches. And it doesn't seem to, as you said, have any rhyme or rhythm. Now, I think for you and I, that's pretty clear that there's obviously other systemic factors driving healing, and we've discussed in previous discussions things like nutrition and what effect that has, what, the hormetic environment has, their inflammatory status, how their body typically responds to those things, what their immune function is like. There's probably the main driver, and I'm hoping that over time, investigation into those things starts to elucidate, okay, well, that's why this person, even if it's not a lumbar stress fracture, another stress fracture, why this person's healing and this one's not.
Yeah, absolutely.
Right? Irrespective of loading. But it seems really clear that in a case like that, what should your approach be? Do you sit around and wait for it to heal, or do you sit around and wait for it to not maybe heal? Because now you're 8 to 12 weeks down the road and nothing has changed in terms of, say, the re-imaging that you get. And what I found really interesting about that, talking with some colleagues, and I lent on a few people, Whereas their experience is there's a number of athletes that basically end up going their whole career with the pars defect never healing. So it's like, well, if it never heals, and the main factor to take note of is whether there's bony edema, so like more of an acute response on a chronic problem. Is your job maybe just to settle the acute phase and then get on with it?
Yeah, and like it's interesting to use this as an example because we also know that a lot of athletes may have a pars articularis defect, yet actually
don't even know about
it complete
because
their
there
whole
isn't
career.
that more acute on chronic effect.
And again, that's not to say like I'll just go for broke, but again, there's something going on here where some people then perhaps obviously adapt to the fact that they've lost some structural integrity, but they create different neuromuscular patterns to accommodate that. But then again, you also have some people who do heal. So there's either some biomechanical or some other systemic factors that influence their ability to heal more effectively. And I think that's where it always comes back to, once you've identified what's going on, we have to go to that framework of why.
Yeah.
Like that's really where it comes to. And sometimes that might be really obvious, like they've just done too much loading.
Yep.
Like, simple as that, okay? Well, we need to titrate loading maybe for a period of time and think about gradually increasing it. But at the same time too, we need to think about some of those hormetic factors as well, because I think where a lot of the answers may lie is not just looking at the actual mechanical factors that we can control, but how the tissue responds.
I think, and I think hopefully that's where it will go, because obviously a lot of this research has been done in cricket players, particularly fast bowlers, because that's the main injury that they get is, lumbar stress fractures.
Yeah.
And with all the money that's in cricket, they still seem to have problems where particularly developing fast bowlers have this issue of having these pars defects. And it's an interesting one because, as I said, like they've become more and more conservative over time with the amount of bowling they do and all of that kind of stuff. And I don't know that it's really changing the presentation of it. There's associations, they believe, with the way that they bowl, so the technical aspect of it, what type of action is, front on, side on, mixed approach, and some of them seem to have stronger correlations with the development of these type of injuries.
Yeah.
But sometimes, or often, you will have an athlete who doesn't have, quite any good technique. Their technique is sort of probably in the more high risk category. They bowl a lot and they still don't get injured. And that to me suggests that, okay, that relationship between load and necessarily the development of these injuries is not as clear. It's more of some correlation, but it's clearly not a causation thing.
Well, again, it's that issue too of like, I've talked a fair bit about this recently, but research provides information about probabilities, not determinism.
Yeah.
It's not that if you get a sudden spike in your load, you're going to get a stress reaction. But there's obviously an increased probability that you may. But then we need to take that into the context of other things. Like a good example is an adolescent who's going through a lot of physical development in terms of growth. Their skeletal system is a lot more immature and is a lot more susceptible.
Yeah, it's reactive in many respects as well.
Completely. And not to mention they may not have, say, tissue capacity development that allows them to be able to create forces in a more efficient way or distribute those forces more effectively through their soft tissue system. In addition to all those other hormetic factors that we've talked about plenty of times when we think about, say, sleep, diet, the type of training that they're doing, the individual profile and so on. So yeah, it starts to open up a bit of a world of going, well, what do you do with all this information? And yeah, I'm probably similar to you. Like, I don't necessarily think I definitely don't think I have the answer, but are we also limiting ourselves in trying to find novel solutions for an individual when we assume that because they have this injury, we need to follow this particular process, yet we're actually limiting their potential to either have a better outcome in terms of healing or return to play better by thinking about, well, why do I actually think this has happened in the first place? Yeah, and not more importantly, I think too, like the big question you asked and we need to think about is, how do I determine what kind of mechanical load I can apply? And yeah, this is where I think we need to think about, well, what kind of parameters do I consider to be appropriate to apply based on the presentation? Like a good example is think about tendon pain. it seems to be very acceptable, and for good reason, that a mild to moderate amount of pain with tendon pathology may be okay.
Well, this is the thing that I'm finding very interesting. And I've brought this up a number of times, and no one's, like, I've had a couple of discussions with the physiologist from VIS. He's a fantastic guy. Super intelligent, super helpful, and really interested. And, you know, we've both spoken about this concept that neither of us are anywhere near experts in, say, bone physiology. But I've been begging this question to everybody, and no one seems to have a really clear answer for me, which is, why is it that in the medical world, if any other sort of soft tissue or connective tissue structure is injured, we're extremely happy to put load through it. So if a muscle, you strain a muscle, within, as Jackie is showing, within a couple of days you can basically be loading it to quite a reasonable level. And that seems to be effective and useful, even in the presence, even in their papers they talk about a mild level of discomfort being experienced during. With tendons, exactly what you just mentioned, the evidence is pretty clear that you can continue to load it even in the presence of pain. You know, people like Peter Malliaris have spoken quite a bit about that, and how you kind of progress through that, and maybe more monitoring for symptoms the next day, or, you know, further symptoms that develop, because obviously we know tendon turnover is a little bit slower and you're not going to necessarily get the response there and then. But with bone, as soon as someone injures a bone and there's a stress reaction or a stress fracture, obviously it's very different if there's a clear mechanical break, like someone, they get hit by a car and they break their leg.
Sure.
You're not going to ask them to walk around on it. It doesn't have enough mechanical integrity to deal with that. But with something like a stress reaction, a stress fracture, why is it that we are overly conservative? Right? That we want zero pain at all times. Often, and we know that loading is actually useful for it, particularly in the long bones. We'll put someone in a boot and say, okay, as long as there's no pain, you can walk around on it. If there's still pain, then we obviously want you to completely unload it. But we don't want any pain with bone, and I don't really understand why. Obviously, there's a very big difference between someone experiencing a 1 or 2 out of 10 pain when they're walking around, say if they've got a stress fracture in their foot or in their shin, versus say like a tendon, the Achilles tendon might be the same thing, versus, having zero pain, and what the difference would be there. I'm not really I don't have any answers, and everyone I ask doesn't seem to necessarily have any answers for me either. And I'm not suggesting that we should go down the path of just saying we'll just push through it. But I'm almost interested to see what would happen if someone was willing to try it.
Well, this is it. We're moving into the massive area of the unknown here. But even if, let's say, for instance, someone could do certain things pain-free, is that actually acceptable? Even if they've experienced no pain whatsoever? Again, I'm not sure. I don't really know here. It's something that I think we need to clearly investigate further. But you raise a good point. And
well, I think, as I said, I've been thinking about a lot. Obviously, I've got a number of people at the moment that I'm managing that are having sort of stress reactions, stress fractures in different parts of the body. And more often than not, to me, it seems like the environment in which their tissue is healing is probably more important than the mechanical loading that we're doing. And what I mean by that is nutrition, their general health status, and obviously associated with that immunological function, the amount of muscle mass that they have around that tissue and what that means. All of these kind of things seem to be bigger factors rather than necessarily load. And even in, one patient, for instance, is one that she's had on and off a series of sort of reactions, or she had one stress fracture, but she's had multiple sort of reactions in her tibia, in that sort of medial tibial stress and bone stress development across multiple periods over a few years associated with running. But her running loads are so low, and typically, it doesn't seem like there is a load factor that's associated with it. But to me, I find it very interesting that load as an external or absolute factor is, in that individual, very low. She developed a stress reaction doing less than 20 Ks a week. So to me, that's more a reflection of the environment of her, body, and how much muscle mass does she have to support that, how much, what's her biomechanical status like in terms of how she runs and what she does, and what actually nutritional environment is there to actually heal bone and have healthy bone turnover.
Did you identify certain things you think that explain it?
Yeah, there definitely were certain things, and we're working through them with other health professionals as well. So we had to obviously bring in other parts and people, as part of the team. Because they're not areas that are necessarily specifically physio managed, but it's very clear to me that load is almost one of the lower priority factors with her.
Well, and this is the thing too. I've had a similar patient who just from the general population in the 30s, quite young, but has stopped running because she just kept developing stress fractures. And again, looking at some of the biomechanical components or her looking at her loading, that she was always very conservative, realizing that she'd had this bout of just one stress reaction or stress fracture after the other, and so has completely given up on the idea of running. But then looking at some of those other systemic factors, particularly her diet, she has quite a restrictive diet, and thinking, well, there's probably some nutritional components that you're missing. But yeah, that's never been something that's really been discussed with her, and again, it's getting out of our scope of practice. But it's interesting and concerning. It's
important for us to sort of refer on you, bring in dietitian, nutritionist, all that kind of stuff.
Absolutely. But it's interesting because, for someone who's in her 30s, doesn't have any type of pathology or condition that suggests that she can't do it, there seems to be something about this individual. It's not a very healthy belief to develop in your 30s to go I just can't run.
Yeah, and I think the thing that I find interesting about it is it starts to put into question, okay, if you get a specific diagnosis, should you follow the protocol that tells you shouldn't load it? Because if load's not the problem, is completely limiting that going to be helpful anyway?
Well, and look, here comes to the main point. If you can follow a protocol and you know that on average you're going to get a certain outcome, the question is, how can you optimize it for that individual? That's really what it comes down to, because we can think about it from a probability perspective. This is probably going to be the outcome you get, and that might be a good outcome. But does that fit within the time frame that's going to optimize for that individual in terms of getting them back to doing what they want to do as quickly as possible? And also, have you addressed the things that you think are going to mitigate future injury risk as well? Because I think that's the other big thing to consider as working in, say, sports medicine or musculoskeletal management, is it's not just about getting them better, but thinking about how you also mitigate their future injury risk as well.
Yeah, and I think that often that clear diagnostic, tissue pathology doesn't necessarily, that's the outcome, that's the symptom that develops. But our job really is to kind of explore what's driven that, particularly in the things that are insidious, that do develop over time. Our job really is to, as you said, see what factors have actually gone into the development. And that, more than ever, I think that's becoming really clear to us. We're kind of probably pretty lucky that we deal with a very active population.
With good health literacy.
Yeah, and generally their behaviours are healthy. But I know that actually even this past week or so, you had a patient that was, general populace and was referred to you through, GP and all that kind of stuff.
Well, she had a surgical opinion and was recommended not to get it, yeah.
Yep. And what was really interesting was they presented, and you seem to have mentioned that you went through a significant process of identifying all of the general health factors that are clearly contributing to the presentation.
Well, look, the more we move away from athletic populations, which not always, but you typically associate with having healthier habits.
Yeah, and for those ones, the things like managing loads is very valuable.
Becomes more and more relevant. But as we start to move away from that and get to more the general population, we've talked about this plenty of times, and actually it's quite interesting when we had a conversation with Paul Coburn, we talked a lot about this. When you're starting to get more these very non-specific presentations, the contribution of both physical and non-physical factors just becomes so much more amplified.
Yeah.
And I find it really interesting when you look at, say, Paul Hodges' work, who has done so much research into looking at factors associated with low back pain, particularly more that non-specific back pain, where, initially a lot of that stuff that him and Gwen Joel did in the 90s of looking at about muscle EMG activity to where he is now. So much more has gone from like just focusing on a very small area associated with the musculoskeletal system to going, oh wait,
zoom out.
Yeah, like there's so many things influencing the musculoskeletal system here, particularly when you think about like even tissue changes and healing and how the local and systemic environment, specifically their inflammatory status, has such a big impact on the process of how tissue adapts or maladapts in response to injury. And so, like what's a lot of the things that his research has highlighted is like, well, you can't just stop doing anything like in the presence of low back pain. That's when you start to see more significant maladaptations change.
I think that's why like people, the best recommendation clearly for non-specific low back pain is be active. It actually doesn't seem to matter what it is.
Absolutely.
Walking, bike riding, pool, resistance training. It actually doesn't seem to matter if you're active. All of the above. Yeah, even if it's all of them, right? It seems much less associated with mechanical loading as it does, as I said, systemic health and staying active consistently.
Well, and look, this I think highlights, going back to what we talked about before, of particularly again general population looking at radiological investigations and their correlation to symptoms, and that the fact is that there is a very poor correlation. And I think the reality is, if you find quote-unquote pathology on an investigation, I'm sure it probably has some relevance, but it doesn't have a lot. And the reality is, for the people who have the same type of findings on a scan, you'll have some who are asymptomatic and some who are symptomatic. There are reasons for that, and we can start to identify some of those things, because you may have quote-unquote pathology, but it doesn't send nociceptive signals because the local tissue environment is such where, say you've got quite a low inflammatory status, therefore your threshold for experiencing nociception is higher, as opposed to someone who has a systemic low-grade inflammatory status because of all these poor health markers, and that's also reflected in that local tissue environment. That threshold for nociception changes because of the fact that those inflammatory markers create a level of peripheral sensitization, not to mention the central sensitization associated with the inflammatory status within the central nervous system. So we can start to appreciate that, sure, we might be able to address some mechanical factors that change how load is created or distributed within that region, and think about specific loading to improve flexibility, strength, and so on. But then we also need to think about that when we do physical activity, we're creating a stimulus not just to the musculoskeletal system, but to essentially every system within the body. And hence why I always find it interesting where there's so much research of looking at how physically active you are reduces all-cause mortality, and also the intensity of that physical activity as well. So clearly we're highlighting here that you need to not look at the musculoskeletal system in that silo that's separate to everything else, and it becomes more prevalent or obvious in the general population.
All right, here is a question for you then. Do you think that we will get to the point where people in the medical, physical therapy world, whatever it is in the health world, will start to recognize that these silos are not valuable? That if you give someone a diagnosis that's, as I said, particularly in the non-specific area or in the insidious onset, that should always come with asterisks of assess general health status, assess exercise capacity, assess, sleep functions, assess all of these other things. Do you think that we will get to that level?
Oh, I hope so. Well, look, again, I do think there is a lot of people who are really trying to advocate that message, of the fact that we see a disconnect, particularly in the general population, of looking at people's presentations with radiological investigations as one example. I think that takes time to filter through, and I think it takes time to change people's perception around pain and the human body, because the reality is the reason why people like diagnoses is because they like to, I think, attach themselves to a particular condition, and they may associate that with particular management or treatment. And I think the other hard thing too is how we manage not just people's expectations but symptoms and the timelines for that. Because I think the other thing that people forget is, again, for the general population who have a gradual or insidious onset, the development of that pathology, not just at the tissue level but even them experiencing pain, is generated and developed over years. And the reality is, I mean, maybe there's some people who've got some really interesting techniques or treatment options. The ability to make changes where they experience less symptoms may not be instantaneous. Now, look, there may be certain particular treatments we can do where we can create windows to improve their symptoms, and I think that's where it's really important from a medical perspective to think about, say, pharmaceutical or analgesics to also help be able to reduce pain in the short term without, creating complications associated with side effects or issues of long-term analgesic intake. But it's one of those things I think we have to, particularly too, we've had a lot of conversations with surgeons recently about, is there anything that gets you interested from a technological perspective that you see as a solution to being able to regenerate tissue, particularly at the joint level? And they all pretty much have the same belief of like, there's a lot of people who have touted, say, stem cell therapy or gene therapy or whatever it may be, but there seems to be a lot of empty promises in it, or at least there's not enough research in it. So I think we need to think about how we manage these chronic types of conditions if we want to actually see better outcomes.
All right. I think that probably covers off on most of the things that we wanted to talk about when it comes to diagnoses. I think the clear message is that even if you do get some sort of diagnosis, you should try as best as you can to explore the other areas and contributors to the development of that, that condition.
Absolutely.
And approach it in a way that uses the evidence that's available, but also the principles that would guide, what protocols are useful and which ones are not. And also allow you to be able to treat that individual based on what you're actually observing.
Yeah, and think about if they need management of factors outside their musculoskeletal system, do you have people that you can actually
I think that's been the biggest thing for us, isn't it? Is trying to find good people. And there's great people in every different area of healthcare. The hard part sometimes is finding them. Or having them close enough that you can easily refer them.
Yeah, absolutely.
Thank you very much for joining us. As always, this episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force platforms, dynamometry and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision making and objectivity. We are no longer guessing. The greatest thing is its ease of use for both practitioners and clients. There are no wires, no fixed setup, and it's a fully integrated Bluetooth system. If this sounds like something that would enhance your practice, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you.